Thank you for inviting us here today, and we're going to go ahead and get started. So a couple of disclaimers just to kind of set the mood and to set our understanding for how we're going to frame the discussion today. We're talking about bleeding emergencies and not necessarily somebody who has an easily controlled or compressible bleed. So everything we're talking about is in the context of a serious bleed that has the potential to be life-threatening. There's a lot of in vitro and ex vivo data looking at surrogate markers and lab values in order to help determine whether or not an anticoagulant works. And some of this stuff we're going to be talking about, especially with regard to the use of PCCs for anti-10A drugs, they're not all FDA-approved things, so that's part of the disclosure we have to make. And just to set a little bit of background for everybody, there's a little over 200,000 bleeds a year, and this is 2013 data, so I'm going to show you why that's changing and why there's going to be a whole paradigm shift in how we're going to be looking at this problem. Most of these at that time were warfarin bleeds, with only a small amount of them being related to rivaroxaban, apixaban, and then later on edoxaban. However, if you look at where we were back then and where we are today and what direction it's going with regard to the use of these anti-10A drugs, you're going to see a steady climb. And even from 2017 to 2018, we saw a big climb, and we're seeing it progress in this direction. And especially with the invention of a drug that's capable of effectively reversing the anti-10A inhibition, we're going to see less and less skepticism and concern on the part of the prescribing physicians about using the anti-10A drugs. So we're going to see those numbers go up, and hopefully it might be the final nail in warfarin's coffin. I'm hoping, because that drug is so difficult to deal with for the patient, both for the patients and for everybody else. So when I started before giving talks on anticoagulation reversal, I understood that a lot of people don't have a working remembrance or working understanding of the coagulation cascade, and why should you? Because that was something horrifying that you learned back in medical school, but I'm going to show you just the important part of it that you need to know to understand all of anticoagulation and anticoagulation reversal. And as I know this is a geeky sort of a topic for emergency physicians to talk about, but it's something that I learned about a long time ago when I gave my first lecture for ASAP on anticoagulation reversal, and then suddenly you become that guy, so you keep reading about this and knowing more about it than you ever wanted to know. You understand how that works. So coagulation is a balance of stopping, or hemostasis is a balance of anticoagulation and procoagulation. Because if it wasn't very tightly controlled, if you got a cut on your arm, you might either bleed to death or clot to death. And you might clot completely solid if we did not have a way of regulating this. So this is a very finely balanced system, and we can add drugs in that are both procoagulants and anticoagulants, and we can shift this system. But when we do so, we're interfering with something that was designed to be very well balanced and to be able to function on its own to prevent problems from happening. So the first part of coagulation is called primary hemostasis, and what that means is you have a cut or damage to the endothelial layer of the inside of a blood vessel. Von Willebrand's factor grabs some platelets and goes on and grabs that opening, and you get a platelet plug. And that's the primary way that bleeding stops. Secondary hemostasis, which we call coagulation, is a little bit more complicated, and that involves ultimately the creation of fibrin, which glues all of these platelets together so that they form a solid clot that is not easily penetrated by blood flow. So you learned something maybe like this, but it was probably a little more complicated. And I always thought that the hemonc guys were really arrogant because they had to use their Roman numerals, and you had to keep thinking every time you looked at one of those factors what that number meant. This is a little easier way of representing this, and I can make this even easier, and I can tell you that anything that's important that you need to know happens on this Y here. It looks like this. And if this is all you need to know, this is all you need to know. And why was 10 afraid of 7? Because 7, 8, 9. And that's the top of that Y. Then we have factor 10 in the center, and we have factor 2 on the bottom. Factor 7 brings his friend factor 5. 10 divided by 5 is 2. You'll never forget that, and it's important to understand this because this is how we get to fibrin, which causes everything to stay glued together. And all of the anticoagulants work at some portion in this Y. I'll show you here. If you have dabigatran or a factor 2 inhibitor, it blocks here. If you have rivaroxaban, apixaban, edoxaban, betrixaban, they work here. Heparin works equally on factor 10 and factor 2. Low molecular weight heparin is primarily factor 10 depending on the generation of the low molecular weight heparin. And warfarin works by poisoning pretty much every component of the system. And the way it works, and this is important to understand how PCCs do their thing with warfarin and how Andexanet, or Andexa now, does its thing. When you take warfarin, it basically prevents your liver from making active forms of 2, 7, 9, and 10. So you make 2, 7, 9, and 10, they're just not active. They don't function. So in order to solve that problem, I can put back in more 2, 7, 9, and 10 in the system, either in the form of FFP or in the form of PCC. And what I'm doing essentially is throwing a bunch of factor back when there's a factor deficiency. That is very different, say for example, when you have an inhibitor floating around in your bloodstream, that no matter how much factor I put back in, it's inhibited once again by that circulating drug. So that's a fundamental difference in how this works. Okay, so what we've actually seen when we looked at the major studies that looked at this, first the rivaroxaban study and the apixaban study, was an overall bleeding rate of between 2 and 3.6% depending on the drug. Now, you cannot extrapolate from this data that because the bleed rate is lower with apixaban, it's a safer drug, because these are two very different protocols, very different ways that these studies were set up. So you can't take that away, but what you can say is that this is slightly better than what we see with warfarin, especially with regard to intracranial hemorrhages. But it translates into a pretty significant problem. So who has a higher risk for major bleeding? Well, people who have major bleeds tend to be older. They tend to have a lot more comorbidities, especially hypertension, coronary artery disease, heart failure, and renal disease. And these underlying conditions take anybody who has a reason to be on an anticoagulant and puts them at a higher risk. And that reflects what we see in our real practice. They tend to be in that patient population. There are some modifiable bleeding risk factors, and why it is important, because it might be an opportunity for a teachable moment. And of all the bleeding factors, risk factors that we have, uncontrolled elevated blood pressure is an important one from that respect. A history of bleeding or a predisposition to bleeding or clotting. A labile INR in someone who's on warfarin. They come in one day, they're 1.5, then they're 3.5, and then 2.0, and then 6. They have a much higher risk. And I wish age was modifiable. I wish I could just anti-age suddenly. That would be really cool. But the drugs that a person is taking are also going to be a contributing factor, especially antiplatelet agents. And if somebody is a heavy drinker, it can increase the likelihood, maybe not just from the alcohol alone, but from the things that happen to people when they are drinking large amounts of alcohol. That can cause head bleeds. So what are the consequences and why do we care? Well, there's an increased mortality in people who have bleeds. There's an increased length of stay and ICU admission rate. There's a potential for someone who has a small hematoma to get a gigantic hematoma, which will subsequently lead to problems. We have an increased utilization of blood components, and when we are transfusing people, there are always risks associated with that, although not great with our modern methods of testing patients, but they're still there. So what kind of bleeding and mortality, what kind of mortality rates are we really talking about here? Well, if you look at the two trials that looked at rivaroxaban and apixaban, we noticed that the overall mortality was 20% in one study and 11% in the other. And again, you can't compare those and say that this one is safer than that one. But what you can do, what you can extrapolate from this, is in both cases, the mortality from people who have intracranial hemorrhages is very high. It's almost approaching 50%. And I want you to remember that, because we're going to come back to that number a little bit later as we talk. So a person comes into the emergency department, they're bleeding, now what? Well, first of all, we need to determine, is this bleeding at a critical site that we might need to intervene in? Is the patient hemodynamically stable or unstable? And is there clinical or overt bleeding to such a degree that they're dropping their hemoglobin by 2 grams per deciliter? And if we see that happening, that's a very bad trend, because that portends further bleeding and further drop. So other considerations, is the patient on an anticoagulant, and have they been taking it, and is there an increased probability that this patient, who you see randomly, is going to be potentially on one of these agents. And we'll talk about some things that might be clues that somebody might be on an anticoagulant. So the definition of the major bleed is a fatal bleed and or bleeding with a fall in hemoglobin of 2 and bleeding in a critical area, in particular intracranial hemorrhage, intraocular hemorrhage, retroperitoneal, pericardial, things that are not easily compressible or easily stoppable. And I didn't mention this, I should say, we do see a lot of patients who have GI bleeding in addition. So some things that can sometimes help us a little bit is to understand the patient's renal function and their ability to eliminate their clotting or their anticoagulant. And understanding their renal function will be able to help us predict whether or not this person is going to be at a higher risk of taking the drug and a higher risk of not eliminating it appropriately, so their anti-10A levels may be significantly higher. We can also do coagulation testing, although unfortunately some of the anticoagulation and coagulation testing that we do is not something that is reported to us in real time, especially with the new agents. But if we do have the ability to have that answer quickly, it might be useful in some cases to make a decision. So how do we understand whether or not someone is anticoagulated? If they're on dabigatran, we can do a PTT, and that should be elevated in most of those patients. Better than that, if you did a dilute thrombin time or an eccrine clotting time, that may have the same kind of predictability of anticoagulation that we see when we're talking about PTT for heparin. When we talk about any of the anti-10A drugs, as you can imagine, the anti-10A levels are going to be probably the gold standard that we're going to be able to look at in order to tell whether or not this person's appropriately anticoagulated. However, in rivaroxaban, it is possible that you might see a rise in PT, and in fact, a lot of people who are on the drug will have an elevated PT. The same is true with the other agents, just to a much smaller degree. And if they have a completely normal PT and they're on rivaroxaban, it probably means that they have not taken the drug or they're outside of a window where the drug is having any effect. This is much less reliable when we talk about apixaban or edoxaban. So a high index of suspicion for somebody who might be on an anticoagulant, people who are on VTE prophylaxis after hip surgery or knee surgery, people who have had ACS, people who have had a VTE, and especially in patients who are medically ill who might just simply be on an anticoagulant to prevent the problem. We do see that in certain types of cancers. People who do have an active VTE, and VTE again is DVT and or PE. People who have atrial fibrillation are almost always anticoagulated to one degree or another. And if somebody is on long-term therapy because, let's say, they have an underlying hypercoagulable state after a DVT, it might be that they're on that stuff for longer than 6 months. So the 2018 CHEST guidelines now suggest considering reversal in patients where a DOAC is suspected, and to do this before anticoagulation tests are finalized. Are you comfortable with making that decision without having an anti-10A level or any other anticoagulant measurements? So what do you think? Do we wait for anticoagulation tests? Or are there times when you should? Are there times when you should say, no, I just need to act right now?
So personally, I think it's got to be looked at on a case-by-case basis. No two patients are identical. In the middle of a resuscitation, you guys all know this because as ER physicians, we're doing things all the time to treat things without even knowing what the necessarily underlying cause might be. If I have an index of suspicion that someone might be on an anti-10A, I might indeed react without getting an anti-10A level. I can't get an anti-10A level in a timely manner, and to wait might mean that that patient's going to incur additional morbidity and mortality. So in certain circumstances, I'm very comfortable initiating reversal without having an anti-10A level back.
I would agree with that, and I would say there are probably times when somebody has a very small bleed that you know is going to potentially become worse over time, and you do have the availability of some types of testing. And let's say, for example, you have TEG, thromboelastography, or ROTEM available. Those tests are actually pretty much real time, and they can tell you if an anticoagulant is present. Now, not every institution is going to have that, especially smaller places. And although we do have it at our hospital, it is limited in scope, and we are trying to bring it down now to our trauma cases. So in what types of patients are you going to consider reversal? We said already pretty much what you guys are saying. The one to think about that's sometimes problematic, that is occult, is the patient who's had a cardiac catheterization and comes in a few days later with back pain and ends up with a retroperitoneal hemorrhage. That's one of the sneakier ones and I've actually taken care of that. And because my hospital's a tertiary referral center, we get a lot more of these in, and I was having this discussion with someone earlier, than a lot of other centers because they're feeding these patients to us who come in after these bleeds.